Assalamu alaikum wa rahmatullahi wa barakatuh. Today, inshallah, we'll speak about how to take history from a patient with respiratory symptoms as a bridging course for the fourth year medical student. First of all, I have no conflict of interest regarding this talk. Our scheme history of history taking, chief complaint, history of a present illness, past medical history, systemic inquiry, family history, in addition to the occupational history, drug history, and social history. First of all, you have to introduce yourself, your name and your role, which year you are. Confirm the patient details, take the patient name, date of birth, explain the need to take the history, and gain a consent. Ensure that the patient is comfort. Presenting complaint. It's important to use an open questioning to elicit the patient to present complaint. شكوى المريض. وهذه يعني لازم أن تؤخذ وتكتب بنفس الترمينولوجي أو ال يعني the patient what he mentioned exactly. No medical terminology. ممكن patient complain of dyspnea. We should not write that chief complaint is dyspnea because dyspnea is a medical terminology. So we have to ask a patient and check if the patient complain of shortness of a breath. So what brought you in today? Tell me more about your symptoms. Allow the patient to time to answer, trying not to interrupt or direct the conversation. And the chief complaint, as we mentioned, in the patient word, we have to mention it. History of a presenting complaint. History of a present illness or history of a presenting complaint should be multiple risk factor, onset, duration, severity, course. Is it intermittent or continuous, precipitating factor, relieving factor, associated feature, and previous episode. Of course, the K respiratory symptoms: dyspnea, cough, wheeze, hemoptysis, chest pain, other systemic symptoms or constitutional symptoms like fever, night sweats, weight loss, anorexia. Sometimes we put recent travel here because recent travel to endemic area with TB, with tuberculosis is very important to mention it in the history of a present illness. So the symptoms will start with the cough. Reflex act as of forceful expiration against the closed glottis, generating a positive intrathoracic pressure as high as 300 mm mercury. Aim is to clear the airway. Cough. Very important symptoms in respiratory symptoms. Depending on the duration of the cough, we can classify cough into three categories. Acute cough less than 3 weeks. Upper respiratory tract infection like pneumonia, pulmonary embolism, congestive cardiac failure, always presented with acute cough. Subacute cough from 3 to 8 weeks, viral infection, post-infective, post-nasal drip, gastroesophageal reflux disease. Chronic cough, any cough persisting more than 8 weeks, like pulmonary tuberculosis, bronchial asthma, COPD, bronchogenic carcinoma, eosinophilic bronchitis, post-nasal drip, gastroesophageal reflux disease. Drugs like ACE inhibitor or congestive heart failure. Sometimes we have to ask about also the cough, the diurnal variation. Nocturnal cough usually caused by post-nasal drip, gastroesophageal reflux disease, chronic bronchitis, bronchial asthma, obstructive sleep apnea, left ventricular failure or heart failure, and aspiration. Sputum. In sputum we have to ask about consistency, amount, and the color, postural variation, and smell. Consistency: serous upper respiratory tract infection, a mucoid like in a chronic bronchitis or bronchial asthma, a mucopurulent in bacterial infection. Bronchiectasis can cause copious amount of the sputum production, lung abscess, and necrotizing pneumonia. The color: usually yellow, green in bacterial infection, rusty sputum, it is the caused by pneumococcal pneumonia or streptococcal pneumonia. Blood tinged sputum in case of TB, frothy sputum with blood tinge in acute pulmonary edema. Second key symptoms and respiratory symptoms is dyspnea, which is unpleasant sensation of a breathlessness. We have to ask again about onset, course, duration, severity, aggravating and relieving factor, postural variation, and diurnal variation. Labored breathing is a physical presentation of respiratory distress, and of course there are many causes that cause dyspnea, like acute dyspnea, acute within minutes, like in pneumothorax, asthma, pulmonary edema, embolism, laryngeal edema, foreign body inhalation. All these can cause acute onset of dyspnea. Rapid, within hours or days, like in pneumothorax, pneumonia, acute bronchitis. Or slow, within months or years, like in emphysema, COPD, pneumoconiosis, or lung fibrosis and interstitial lung disease. So we have to grade the dyspnea. How short of a breath is the patient? When does it come? By exertion or at rest? Does it come in attacks, paroxysmal, and the patient free of symptoms in between? Does the patient have attacks of breathlessness at night, nocturnal dyspnea, or does the patient have to sit up, or can he sleep lying down? Orthopnea. طبعا grading dyspnea very important. We depend on the modified medical research council of scale, modified medical research council of dyspnea scale. Grade give us an idea about the severity of the dyspnea. Like patient dyspneic is the patient feel dyspneic at rest, or he is too breathless to have to leave the house. So dyspnea at rest, or the patient is dyspneic at rest, this is grade 4 in modified medical research council. If the patient became stop for breath after walking about 100 yards, this is grade 3. If the patient walks slower than the people in the same age, it's grade 2. And if the patient is get dyspneic only with the strenuous exercise, this is grade 0. Aggravating factor like exposure to allergen. Dyspnea sometimes aggravated in after exposure to allergen, with exercise, when drugs or cold weather. Relieving factor, medication, the dyspnea relieved by inhaler or at rest or removal of the allergen. Diurnal and postural variation in bronchial asthma, lung abscess, and bronchiectasis. So the dyspnea is exertional, paroxysmal, orthopnea, or at rest. So paroxysmal dyspnea, patient with bronchial asthma, cardiac asthma, recurrent BE, gastroesophageal reflux disease, they have the paroxysmal attacks of dyspnea. Orthopnea, dyspnea on recumbency, which is partially relieved when sitting up. It's common symptoms of left side heart failure. Also, orthopnea condition, sometimes there is other condition can cause orthopnea. Increase in intra-abdominal pressure, massive ascites. Sometimes in patient they have pregnant lady in the 7 months or 8 months, also they can have this orthopnea. So differential diagnosis of orthopnea: massive ascites, retrosternal goiter, bilateral basal bronchiectasis, bilateral paralysis of diaphragm, late months of pregnancy. Latipnea, axial orthopnea, dyspnea on standing or sitting, relieved by lying down. Like this patient اللي هم عندهم right to left cardiac shunt, AV malformation في الناس اللي عندهم hepatopulmonary syndrome, recurrent BE post pneumectomy. Tripopnea, dyspnea on lying on the affected side, relieved by lying on the healthy side. The most common cause of tripopnea is pleural effusion, suppurative lung disease, chest wall tenderness, and sometimes in patient with left side heart failure. Coughing till you vomit is a bronchospasm till proven otherwise. يعني إذا أجى العيان بيحكي إنه he's coughing, having attacks of frequent coughing, then he vomit, we have to consider there is a bronchospasm. Vomiting, then start the patient to cough, we have to think about aspiration. Differential diagnosis of shortness of breath: the most common طبعا الأزمة, COPD, congestive heart failure, ischemic heart disease, pneumonia. Sometimes psychogenic can cause dyspnea. Urgently life-threatening condition like upper airway obstruction, foreign body angioedema, tension pneumothorax, pulmonary embolism. Third symptoms, chest pain. If any case with history of present illness, the pain, we have to clarify the details of the pain, ولازم using the Socrates. Site, site, where is the pain? Onset, when did it start? Sudden versus gradual. Character, sharp, dull, aching, burning, stabbing, heavy, tightness. Radiation of the pain, does the pain move anywhere else? Radiated to the left arm, radiated to the lower jaw, to the back. Association symptoms or associated symptoms like other symptoms, nausea, vomiting, sweating. Time, course, worsening, improving, fluctuating, exacerbating and relieving factor. And the severity of the pain on the scale of 10 to 0 to 10, how severe is the pain? طبعا severity of the pain on a scale طبعا from 0 to 10, how severe the pain is. History of a presenting complaint, radiation, dyspnea, it is exertional, orthopnea, paroxysmal nocturnal dyspnea. The dyspnea is it is exertional. Orthopnea, B&D's differential diagnosis of paroxysmal nocturnal dyspnea is either bronchial asthma or left side heart failure. How we can differentiate between both? Paroxysmal nocturnal dyspnea secondary to asthma or secondary to the left side heart failure. We can differentiate by the time of onset. If the patient sleep and he wake up after 30 minutes to 1 hour early, So this is most likely secondary to the heart failure. If the patient went to sleep and he wake up after 3 to 4 hours because of vasovagal bronchoconstriction, this is most likely secondary to asthma. Relieving factor. The asthma, if the BND is secondary to asthma, relieved by inhaler, salbutamol inhaler. And also if the patient associated with other orthopnea symptoms, lower limb swelling, raised jugular venous pressure, most likely this paroxysmal nocturnal dyspnea secondary to the left side heart failure. Peripheral edema is also important, and fever in case of pericarditis, osteochondritis, and pneumonia. The time, duration, minutes, hour, days, weeks, worsening, relieving or aggravating factor, and the severity. Retrosternal pain, most likely cardiac, angina, myocardial infarction, myocarditis, pericarditis, mediastinal like enteritis or malignancy, aortic dissection and aneurysm, esophagitis, esophageal spasm. Peripheral chest pain secondary to the pneumothorax, infarction, pulmonary embolism, musculoskeletal chest pain, sometimes a breast disorder, and sometimes a neurologic like intervertebral disc prolapse or herpes. And anxiety can cause also peripheral chest pain. The onset is very important. Sudden retrosternal chest pain in myocardial infarction, pneumothorax, pulmonary embolism, esophageal rupture, peripheral in pneumothorax, gradually in exertion like an angina, after vomiting, esophageal rupture, and constant pericarditis, musculoskeletal, and GI. The duration, usually angina less than 20 minutes. If the chest pain, retrosternal chest pain lasting more than 30 minutes, it's most likely secondary to myocardial infarction. Characteristic and severity. Character and the severity. Stabbing chest pain, pleural, and sometimes pleuritic chest pain that aggravated by taking deep inspiration. Hemoptysis. Hemoptysis is another also symptoms. We have to ask about the volume of the hemoptysis. Hemoptysis, coughing up blood, the volume, if it is 100 ml or less within 24 hours, it is most likely secondary. Consider it is mild hemoptysis. Moderate, from more than 100 to 400 within 24 hours, it's considered moderate hemoptysis. And massive hemoptysis more than 400 ml per 24 hours. Sometimes 100 ml per hour of coughing up blood considered as massive hemoptysis and need urgent intervention and management. Also the wheeze, what is considered symptoms and sign. الويز يعتبر symptoms and sign. We have to ask about diurnal variation, 9-time wheeze. So dyspnea, orthopnea, BNDs, lower limb swelling, chest pain, and wheeze. Then we have to ask about constitutional symptoms like fever, night sweats, weight loss, anorexia, and history of recent travel or exposure or contact with sick patient. Past medical history. We have to ask about the respiratory condition like past medical history like asthma, pneumonia, COPD, pulmonary embolism, malignancy, TB. cardiovascular disease, neuromuscular disease, past surgical history, any history of ICU admission or recent hospitalization, also is very important to mention. Drug history, is the patient in regular medication? Is he taking inhaler like a preventer or reliever, like rescue inhaler, salbutamol inhaler, or inhaled steroid or oral steroid, diuretics, antibiotics, sometimes oxygen or home oxygen. Medication that can cause respiratory side effect, we have to ask about beta blocker, non-steroidal anti-inflammatory drugs which can cause bronchoconstriction. الACE inhibitor ممكن تعمل dry cough. Cytotoxic agent اللي cause interstitial lung disease like الميثوتريكسات والamiodarone. Patient in oral, if the patient in oral contraceptive pills with increased risk of pulmonary embolism with allergy, allergies also, we have documented this clearly. Family history, respiratory disease, family history of asthma, atopy, lung cancer, cystic fibrosis, recent contact with other who were unwell, viral infection, pneumonia, TB. Social history, smoking, how many cigarettes a day? يعني we have to mention also how many pack year. How many pack year we can calculate it by multiplying the number of cigarette, if it is 20 by the number of years. يعني if the patient is smoking 1 pack of cigarette per day for the last 5 years, we can mention the patient is smoking history 5 pack year. Alcohol, how many units a week, recreational drug use, cannabis, living situation, الhouse flat, ventilated, there is a stair, home oxygen or not, who's live with the patient, any care or input, daily activity. Also we have to mention the occupation of the patient regarding respiratory history taking is very important. البيشنت اللي شغال في الشيب يارد construction البلمبر ممكن risk of asbestosis. الناس اللي بيشتغلوا في المناجم والماينرز النيموكونيوسيس والفارمر بيكون عندهم risk of having extrinsic allergic alveolitis. And a patient with hobbies also paired fancier allergic extrinsic alveolitis الاسم القديم واللي هو اسمها الجديد اللي هو hypersensitivity pneumonitis. Travel history, high risk area for tuberculosis or recent long flight pulmonary embolism. A systemic inquiry involve performing a brief screen for symptoms in the other body system. ممكن تكون الأشياء ما ذكرها البيشنت وبالتالي is very important to ask about systemic inquiry. طبعا في الهيستوري تيكينج بتاعت we mention الcardiovascular respiratory already we ask the patient about these symptoms, so we have to ask from GI, appetite, nausea, vomiting, dysphagia, weight loss, urinary volume of urine, frequency, dysuria, urgency, CNS في الفيجن, headache, motor or sensory disturbance, والmusculoskeletal bone and joint pain or muscle pain, any skin rash or skin breaks or ulcer or lesion. By this we can close the consultation, we thank the patient, then we summarize the history of the patient. Thank you.